Hello, my name is Emily Warr. I am the Director of Operations in the Center for Telehealth at the Medical University of South Carolina. And today we'll be talking to you about our experience during COVID with rapid implementation of an outpatient COVID-19 home monitoring program. If you have any questions during our presentation, please feel free to use the chat icon and enter your questions, and we'll answer them at the end of the presentation. So for a little bit of perspective and history, obviously, this has been an interesting year for all of us, and COVID has impacted every one of us here today in varying and different and highly impactful ways. But at MUSC, we feel, I think, very fortunate to be able, because of the support of the state legislature and because of the support of our leadership here at MUSC, we felt really well poised to respond to sort of the curveball that COVID threw us, if you will, and really we're able to step up and help the state in a way that we're quite proud of. Specifically, you may have seen some of the media coverage of some of the activities around our COVID response within the Center for Telehealth, specifically around sort of virtual care and our virtual urgent care platform being converted to an entry point for COVID testing. And so as we move on to the next slide, I'll show you sort of our how we designed our COVID response with engagement, sort of patient engagement cycle in mind. You can see, obviously, everyone in the state of South Carolina was an at-risk population as the virus was spreading. And so we decided to use our already widely adopted virtual urgent care screening tool to convert that to, as I said before, an entry point for COVID testing. And the goal there was to keep those patients that were symptomatic or thought they may have been exposed in their homes and able to connect with a provider. The provider worked through some questions with them and then was able to decide if they needed to be tested for COVID or not. At that point, we were able to actually get them plugged into a scheduling mechanism to come to either one of the, at first, sort of the drive-through locations locally in Charleston, but then rapidly escalate to pop-up centers and standing centers for testing across the state of South Carolina. So that's sort of the entry point. But we didn't want to stop there, right? We didn't want to fragment our care. And so that's sort of where we take it to the next step of the engagement cycle. We all of the virtual urgent care screenings and testing then came through our EHR at MUSC, which it happens to be Epic. We had strong integration there, and thus we're able to see, obviously, the results. The resulting came through Epic, and nicely, I think we were able to use the MyChart application largely within Epic to offer results to the thousands and thousands of South Carolinians that we tested both here locally in Charleston and then beyond across the state as the pandemic continued. So some automated resulting processes, both for negative results and positive results, were integrated here. So I already mentioned the MyChart mechanism, but we also had automated batches for text messages and emails to those patients who were negative, so to try to expedite resulting to patients. The soft touch entry image there just sort of, again, shows how we were attempting to meet the patients where they were in their homes to keep them out of our in-person locations where they might expose other patients and or care team members. And instead, the decision is made sort of at the point of care, virtually within the patient's home, and then they're dispatched to drive-through testing. Once a patient is deemed positive, then they become sort of eligible for the remote patient monitoring program that we'll describe here. And specifically, this program was intended for higher risk patients who may have complications that would lead them to either be hospitalized or have sort of a rougher course, if you will, with COVID-19. And so we did some targeting of populations that Cheryl will describe in a few moments. But that was an entry point once a patient was positive to potentially be integrated into this home monitoring program. And then you also see over here to the far left that we built some hospital-based programs as well for during COVID-19, specifically around decreasing healthcare worker exposure using technology, and also family visitation using technology, because at least here at MUSC, we had to shut down visitation for some time and have opened it up a little bit, but still only are allowing one family member in for each patient. And so this family visitation application has been used widely. So as we move into the next slide, I want to introduce Cheryl Hamill. She is the remote patient monitoring coordinator at the Medical University of South Carolina and was integral to building this remote patient monitoring program specific to COVID-19. So Cheryl, take it away.
Well, thank you, Emily. I appreciate that. And welcome, everybody. I look forward to our presentation and hopefully conversation over the next few minutes. I have been at the Medical University of South Carolina coming up about 5 years, but had the opportunity to join the Telehealth Center in February as our lead remote patient monitoring nurse coordinator. So intentionally over time, COVID will be just the beginning of many innovations that we have to engage patients across their care continuum. But for today, we're going to do an overview of the COVID RPM that Emily has briefly touched on in the engagement cycle for COVID. Our overall mission for this program is to provide what I call a safety net for our COVID-19 patients, hopefully engaging with them early in their home recovery or home quarantine time, and when necessary, actually helping them to navigate to urgent or admitted patient care services for further treatment. We do target 100% of the COVID-19 patients, but we have made decisions over the last 6 months to really center more on those patients, as Emily mentioned previous, that have higher risk. And we'll talk a little bit more about what that risk profile looks like. I do want to acknowledge our physician champions. They have been ominous and very, very helpful and integral in our development of this program. We've partnered closely with MUSC's Department of Family Medicine, with Dr. Vanessa Diaz and Dr. Marty Player, and also with Dr. Ford in our university side, our biometrics informatics center. Emily has served well as our operational lead, and we have also partnered very closely with our Division of Infectious Diseases. So all patients that do test positive do not require hospitalization. So offering an option for them to feel safe and to feel connected while they're in the home is what we ultimately have been goal setting for this program. And as I mentioned before, when appropriate, facilitating a smooth transition if they do need to become inpatient to get continued care for their COVID experience. We do have metrics of success to share with you all today. We're not going to go into granular detail on that. We are still evolving more demonstrative outcomes from our program that depend a lot on creating more information from our COVID positive registry. But we will share some preliminary and very exciting data. So when we say rapid implementation, that's an understatement. COVID came in like a lion. As I mentioned, I started in February, and we had this COVID RPM initiative up and running the last week of March. So that's really unprecedented at MUSC. And in terms of actually engaging with build time in our electronic health record and leveraging new innovations through our patient portal, MyChart, we were able, with our partnership with the Biometrics Informatics Center, to really accomplish a lot in an extremely short period of time. We also, I mentioned our physician champions engaged with clinical faculty that had expertise and evolving expertise in how to manage COVID-19 and created a patient-reported symptom checker that was integrated into the electronic patient portal, again called MyChart. This was designed with patient-centered language so that it was easily understandable by the patient or their caregiver in the home. And this is an example, as you see on your screen, of what that looks like to the patient or their caregiver when they log in to the MyChart portal. So as I mentioned, we went live March 30th, and this information we're sharing today is through really the later part of September. So MUSC, through many avenues that Emily touched on, has to date tested approximately 12,000 patients that have turned up as resulted positive for COVID-19. As we mentioned before, we're very MyChart interested, since many of our patients at MUSC are already navigating their care delivery through MyChart. So of that 12,000, over half of them had MyChart activated at the point that they were COVID tested. Some innovations on our side is a reason that we chose to use MyChart in Epic is because with our COVID testing experience around the state, every patient tested, whether they have any history at all at MUSC for care, are assigned a medical record number and are offered the opportunity to develop an access point to their MyChart. So that's also innovation that had not been tested before. Of the home monitoring program that we're talking about today, we have documented in our electronic health record, Epic, over 12,000 individual home monitoring patient encounters. And that is just representing our COVID positive patients. Exclusion for that would be patients that did not have MyChart on enrollment and had to be assisted to activate their MyChart. Out of that 12,000 patient positive patients, we have enrolled just a little over 870 patients in our program. We did have to start to make decisions that who would benefit the most from having added monitoring at home, and created a risk stratification model. So on our first call with the patient to tell them of their positive resulting, we do a courtesy review of their symptoms at the time that we're calling, and also do a brief review of their health history, and assign a risk of COVID complications based on their symptoms on that date and their histories. Of the 870 patients, I thought this would be interesting to share that 26% of them presented as high risk, either by symptoms that they were reporting on the day that we called, and or based on their comorbidities. Medium risk were 32%, and low risk around a third of the patients. So we have chosen for this point forward to continue to alert patients of their test results, but only offer enrollment to those that meet the medium or high risk benchmark. So to date, we have had 2,600 patient assessment questionnaires completed, either through a direct log on to their MyChart and or if we have not heard from a patient, actually making a telephone call on their behalf and completing the symptom checker with them on the phone. We use a centralized pooled nursing approach, meaning that in our telehealth center, we have a bank of nurses that cover our program 7 days a week. We run our monitoring program between the hours of 7 a.m. and 7 p.m. Saturday through Sunday. In our review of our encounter tracking, which we do in Epic, we have been able to aggregate our time over the last 6 months, and I can share with you that just our COVID remote patient monitoring experience has equated to approximately 40 minutes of individualized patient time over their home quarantine period of 10 to 20 days. And again, if you have any questions, make sure and use the chat feature. So this is a schematic of what our workflow looks like, and this is very nurse-centric. I thought for purposes of today, we would think about at what point is there an escalation in our workflow that requires added attention beyond what our nurses provide through their monitoring and telephone calls. So at the point that we review a symptom assessment that has been self-reported through the MyChart, and or if we're on the phone, we make a determination that based on symptoms and just health status, that we need to make 3 different decisions. One would be to consult directly with our telehealth physician consultant on what we are seeing with that patient in real time. Or the patient has a primary care provider of record, either at the Medical University of South Carolina or outside. And we are helping to navigate a same-day visit for that patient with their primary care provider in hopes of potentially averting an unnecessary trip to the emergency room. And then lastly, and sadly, there are enough times that we can talk about today that we do make the call based on a symptom assessment, and we actually determine on the phone that that patient's best next step is to present to the closest emergency room. And we do assist that patient with a seamless experience to their nearest ED, and that is not exclusive to Medical University of South Carolina. So we do call with an update to the charge nurse at that emergency department. So really everything that we're doing is about patient engagement, and we really do take very seriously the experience that the patient is reporting to us while they're at home recovering and completing their quarantine. So at the point that they are feeling better, their symptoms are improving, and they are within the guidelines of the South Carolina Department of Health and or the Centers for Disease Control, we do make personal contact with that patient and offer them what we call graduation rather than disenrollment. And we really celebrate that they're feeling better and that they're on the other side of this condition. We revisit with them their testing information, the date of their resulting of COVID, the date that they received notification that they were positive, and we revisit the date that they enrolled in their monitoring program. We talk about practical things like returning to work. We revisit often the moving guidelines that happen with DHEC and CDC. We talk about the relevance or not for retesting and what the options are now for someone that needs to go back to work or has other special situations. We really promote the opportunity for patients that are graduating, presuming that they have developed a healthy immune response with antibodies to COVID, to consider convalescent plasma donation. We have seen many anecdotal examples of our most critically ill patients in the hospital being the beneficiary of patients in our home monitoring program actually taking the time to go and donate plasma post quarantine. And we do ask for feedback. we have done many cycles of improvement over the last 6 months based on what patients and their caregivers are telling us, because even at this point, everyone knows that COVID has not gone away, and we will continue to do this particular remote monitoring program as long as it's of value to our patients. We also invite the patients to provide that feedback through 2 mechanisms. One is a REDCap survey, with the option at the end of the survey to provide contact information if they would be willing to participate in a brief telephone interview with our telehealth quality coordinator. To date, we have had approximately 100 of our 750 patients that have been enrolled to actually respond to our survey, and 53 of those have participated in the telephone feedback, and this has proved to be invaluable to our constituents, our stakeholders, and our patients and families. So some of you might be aware of the Patient and Family Centered Care Institute. The Medical University of South Carolina participates fully in the principles of patient and family centered care. And I really think that this remote patient monitoring program is a wonderful example of patient and family centered care. The key principles being dignity and respect, the sharing of information between the care provider and the patient for purposes of empowering the patient and family to feel that they're being useful in their own care delivery. Active participation by encouraging their active use of the MyChart questionnaire assessment on a daily basis. And then our collaboration with them. I mean, we don't do things to them, we help to work with patients. So it's really a very empowering experience for patients. I think this program has really demonstrated that it makes our patients and families feel that there's a sense of trust between the institution that tested them for COVID and helping them to get to the other side of COVID, what we call the healing side of the experience. They don't feel that they're alone. And since this primarily is met at home with quarantine, it means that you can't have patients, families, and visitors that would regularly be at their side helping them to, to make it through a really complicated and sometimes a very difficult illness at home. And in many ways, they have greater access to care. Many of our patients would not have chosen to actually go to the ED out of just basic fear of going to the emergency room, or they're in very disenfranchised or rural parts of the state, and actually getting to primary care setting is not even an option for them. And truthfully, they feel that they were an active participant in their care experience. These are some real responses of our patients giving us feedback, and I think it just really demonstrates what I've been describing for you all. A patient said, I felt comforted to have some form of contact as my family couldn't come and visit with me. This program gave me the assurance that I would be able to handle this because, I was really scared. They took care of me. They were watching out for me. I would have probably gone to the emergency room 2 or 3 times without the knowledge that someone was watching and was going to contact me if I was in trouble. Part of our offering when they agree to participate in the survey at graduation is a development of what we call a Net Promoter Score, and I'm sure many of you in the audience are very aware of that. It assesses to what extent that the patient would recommend this program to their friends, to their relatives, to their colleagues. And with those 101 of our patients that have so far provided us input, 86% of those that responded are what we call promoters. They would be the enthusiasts that would absolutely refer remote patient monitoring for COVID during home quarantine to others. 5% of our patients were just neutral. They were satisfied, didn't really have, a bias one way or the other. And then we did have a few, 10% that were detractors. Maybe they were unhappy. When we drill down and look at what that response was, it really was up personal to the experience they were having with the actual monitoring with the nurses, but it was really getting more familiar or getting the hang of what it means to actually log into my chart and to complete the questionnaire. So even if early on they struggled a little bit, they would reach out to a friend or a family member that could help them, and or on the phone, the nurse could assist. We also do have a help desk for my chart, so that has also proven to be very helpful. So our overall score to date is 76, and in the world of net promotion, anything above a 50 is considered excellent, and I feel very honored to say that this program would be considered world-class. And with that, we would like to think about where we want to go. And Emily, please feel free to contribute and add added comments as you're able. Again, that commitment to patient-centered care across the continuum. COVID has really touched everybody. Patients that have other health conditions, chronic illnesses like diabetes, congestive heart failure, pregnancy, hypertension, other immune suppressing conditions. And so we really began to see that there was a lot more opportunity for us to think about expanding from COVID to other types of remote monitoring that we could build off of the lessons learned from our COVID experience. And also, Emily, you could probably speak to this as well, but the CMS is now definitely promoting reimbursement for monitoring at home. And we are certainly looking into what those opportunities will be for us in the future to be able to capture all of the time that we have so far contributed with our remote patient monitoring nurse pooled approach. Anything on your end, Emily, that you would like to add to our next steps?
I don't think so. I think you summed it up really well. I just want to sort of reiterate the patient-centered focus that we chose to take with our COVID-19 remote patient monitoring program, and the success that we've seen and trust, as Cheryl outlined, of the patients has really inspired us to formalize that approach for all remote patient monitoring. And by this, I mean, historically, some of our remote patient monitoring programs that have been very successful have sort of occurred in silos by department rather than with a patient-centric sort of continuity of care approach. And I think we've learned a lot through COVID about the value that I think we all knew internally, the value of that concept, but it's really worked out well in this case, and we will focus on it strongly as we move forward.
All right. Again, if anybody has any questions, please feel free to add your questions into the chat feature, and either Emily or myself will provide you feedback. If there's something that we can not answer right away, we will definitely get back to you with more information.